Now, our first discussion this morning is called The Need and the Opportunities to Disrupt Cancer. And we're starting off very strongly here with these two amazing presenters. We have Professor Michael Boyer, AM, the Chief Clinical Officer of Lifehouse, and Professor David Goldstein, the Department of Medical Oncology at Prince of Wales. Now, they're going to deliver a joint presentation about disrupting cancer, which we're really talking about today. What are the opportunities? Where are we with things like targeted therapy and immunotherapy? And what will it mean for patients with all types of cancers, rare or not? So please welcome our two first presenters, Professor Michael Boyer and Professor David Goldstein.
You can do the Hillary joke.
Thank you and good morning. It's a pleasure to be here in a place which has seen, I guess, lots and lots of political battles over the years. I think it's opportune to think of us as perhaps Donald and Hillary, although Donald and Hillary, I'm not sure if I'm Donald or Hillary, but they would probably take a slightly more adversarial approach. And I think what we hope to show you is, although we work at what might be termed competing institutions, it's very clear that there's an enormous amount of collaboration and goodwill in dealing with the problem of cancer. And indeed, I would say that it is only through collaboration, goodwill, and a lot of hard work from many, many people that we will actually conquer this disease. So let me start, and let me also actually add my thanks to Richard and Kate and to the Rare Cancer Australia team for putting together what I think will be a really stimulating and exciting day. In order to set the scene, I'm going to talk a little bit about the background to cancer, and I'm going to tic-tac in a bit of a tag team with David as we explore where we see the opportunities and the future of cancer care. In this audience, I probably don't need to really remind you of the impact of cancer, but I'm going to anyway, because it's always worth remembering that this is a disease that affects the community. And apart from the very, very early years of people, and I'm not sure that you can actually even see that, apart from people aged under the age of 5 years, it is either the first or the second cause of burden of illness amongst fatal illnesses in this country. And so this is a problem that affects us all and affects us through our lives. It's not surprising if you see that when you then consider how much cancer is around. So each year in Australia, 130,000 people, give or take, are diagnosed with cancer. And that equates to a lifetime risk for men of 1 in 2 and for women of 1 in 3. Now, sitting behind that is something else, and that is that although the rate of cancer is not changing, the numbers are increasing, and they're increasing inexorably, partially because of demographic changes. There are more people, therefore there will be more cancer, and partially because of the thing that we have heard so much about over the years of ageing of the population. And although often in the media cancer is portrayed as a disease of young people, in fact it is a disease of older people, and if there are more older people, there will be more cases of cancer. Also, hiding behind those figures, which are sort of a very stark and perhaps shocking reminder in themselves of how common a problem this is the fact that for every one of those 130,000 people, there is a mother or a father or a sister or a brother or a workmate who often is every bit as much affected by the diagnosis of cancer as the patient themselves is. So I guess I want to get across the idea that this is a community problem. This is not a problem just for the person that is unfortunate enough to be diagnosed with cancer. On a slightly more positive note, we have made advances in survival of cancer. And if I can make this go forward somehow. Oh, there we go. And that little orange line that's heading down is the death rate from cancer. In fact, over the last 30 years, your chance of surviving cancer for 5 years or more has increased from 46% to 67%. So that's very good. But the sad reality is that the number of deaths increase year on year, and that cancer still accounts for 1 in 3 deaths in this country. In addition, the advances have been a little bit patchy. So whilst, for example, the 5-year survival rate for breast cancer is in excess of 90%, that same number for colorectal cancer sits in the 60 to 70% range. For lung cancer, it's about 14%. And for a disease that David spends his time treating, pancreatic cancer, it is stubbornly below 10%. So although we should be happy that we have made advances, we should not give up the fight for those diseases where there is clearly lots and lots of work to do. In addition, there is much more to this in terms of the impact that cancer has than just death rates. So that people who live with cancer have to deal with all sorts of problems, and as a community we face problems in terms of lost productivity, people not being part of the community, lost friendships, impacts on families. So it would be wrong to just look at deaths as a marker of the impact this is having on people. Finally, as we have improved survival, we have the issue to deal with of the prevalence of the disease. That is, the number of people who are currently alive who either have cancer or have survived cancer. And that number is going up, and that's a good thing because it reflects our success in controlling the disease, but it provides us with a challenge of how to meet the survivorship needs of those people. So what we're going to do over the next half an hour or so is talk a little bit about some of the advances across a number of fields that are going to help us to tackle cancer in the future. They include things like understanding the biology of the disease, the way we can use that information to develop treatments, the promise of data and bioinformatics, and finally some of the regulatory and system-wide challenges. So now I'm going to hand over to David, who's going to tell us about biology.
Thanks, Michael. So I'd also like to thank Kate and Richard for giving us the forum for both to bring together diverse people, consumers, patients, legislative and regulatory advisors, and physicians. So let's talk a bit about what's exciting. If I can get some movement here. Right. So what's exciting is the revolution in understanding the biology of how we work, and from that, the dividend of how cancers work. So within each cell, as you can see on the top left-hand corner, is a whole lot of genetic information, all on these chromosomes, and ultimately that's the genome, that whole body of information about how we work. And in each individual cell, certain genes are on or off, and they're on or off to allow it to become a particular type of cell, a liver cell, a kidney cell, because some appropriate genes work and the others don't. That's what happens in the normal setting. Oop. I have to get this right. Is there anybody up there who can advance it for me? Right. So what I'm going to do is talk a bit about how all cancers are becoming rare, which is quite an important concept. This idea that there are drivers, but there's also complexity, and the complexity is getting greater, not less. And there's a variety of issues about that I want to talk about. So is there anybody up at the top who might be able to advance the slide? Right, okay. So I want to walk through this series of slides and just discuss it with you. So, top left-hand corner, there's the genetic information in each of the chromosomes, and they have more or less information. So that wheel is each of the chromosomes with its genetic information. How does cancer actually happen? There is some misinformation or dysregulation that happens so that the correct message is no longer being given. It doesn't stay as a liver cell anymore, or a kidney cell, or whatever the particular organ is. It decides to change. And it's an iterative process. So if you now look at the top right-hand corner, if we think about the development of colon cancer, there's a single gene that goes wrong, provides wrong information, and when a second hit occurs, that wrong information translates into excess growth. But that's not cancer yet. More changes happen, more genetic disruption, a different message occurs, and ultimately moves from a growth happening just in the lining of the cell to an invasive tumour that has gained the biological ability to spread. So you'll remember the Human Genome Project, that ambitious project that cost about $2 billion to try and map all of the human genetic information. So the dividend of that, at a much lower cost, interestingly, was the Cancer Genome Atlas. So all over the world, groups of scientists got together, and their aim was to get enough examples of any one particular cancer to understand all of the genetic changes that happen for that particular cancer. And indeed, in Australia, led by Andrew Biancan, this country was involved in the Australian Pancreatic Cancer Genome Project, where 400 patients' material was collected and analysed in a very deep way to understand what are all the pathways, how did it get to be a pancreas cancer, why is the pancreas cancer perhaps different to a lung cancer, or hopefully, where are the similarities? And that's a lot of the message for today about biology, is the similarities as well as the differences. So what do we end up with? We end up with this enormous pathway of possible changes that happen that can be found when it's finally an invasive tumour. The challenge is to get signal out of that noise, because that's a huge number of pathways. Which one of them matter? And which one of them are passengers? Well, they happen to have changed, but they really don't have a major role to play in this phenomenon, this biological change called cancer. Just can't get it right. Right, okay, so I showed you that final diagram, so my goodness, what the hell are we going to do with that? Fortunately, there are a number of ways to deal with that I'll go through. Next slide. Right, so the first thing that we learned, top, was that in a number of common solid tumours, the genes that go wrong can often be found in each one of those tumours. So there is some commonality. Each individual gene might be 1% of those tumours. That's a major, what we call a driver. That's definitely implicated in the process of this acting inappropriately as a cancer. But number of those drivers, although uncommon in each individual cancer, collectively is a set of drivers for those sets of patients that is an important issue and might be a therapeutic target that can change cancer treatment for that group of people, irrespective of whether it has been identified in the bowel, the lung, or the pancreas. The second way of getting order out of that noise is this understanding that, in fact, all of those genes work together in very specific pathways of how they do what they do. They either, starting from the green right-angled arrow around, they either encourage a signal to proliferate, to grow, or they learn to evade the normal off-switch growth suppression, or they learn to avoid the normal immune system's ability to pick up cells that go wrong, or they become immortal. We all get older, and our cells actually have an inbuilt program called senescence that turns it off, especially when it goes wrong. But there are ways to avoid senescence. Or they promote inflammation that allows growth to occur. Or they promote invasion and spread. Or they induce blood supply that supports the tumour. or they promote instability in the genome so that more things can go wrong that are self-promoting, or they resist the normal cell death. So once you start to know that there's a very limited number of pathways that you need to address to stop cancer doing its thing, you can start to put the different driver genes into those pathways and perhaps reduce the number of strategies you need to identify. Next slide, please. So lung cancer is one example that Michael may expand on, but you can see there are some drivers that are in only 1% of cases, and others, although not as druggable, that are in 25% of cases. But here's some of the difficulty as we move to the bar columns. So you can see that in colorectal cancer, and perhaps the next one to look at would be melanoma, you can see that quite a substantial proportion of that tumour is one particular driver. So that's encouraging. And that's rather why melanoma is now undergoing quite a renaissance in treatment from being a stubbornly resistant one to a much more manageable one because of biologic understanding, which Michael will talk about. But then you look at pancreas cancer, there's no one big one that stands out. There's a multiplicity of drivers. That's why it's a complex disease that we're not doing as well at. But there's hope on the horizon. And what is it? In gastric cancer and colon cancer here, but let's look first at gastric cancer. A lot of those really different small ones actually aggregate into a theme. So that in fact in gastric cancer there's only 4 themes. And once you can work out there's only 4 themes, you can start to realistically think about how to deal with the multiplicity of small segmented changes by putting them into those boxes. And similarly in colon cancer, the magic number 4 has come up again. So despite at the top seeing all those different little bars, in fact there are 4 major groups that they go into. And so we are on the verge of maybe starting to attack complexity in a logical and ordered way. Next slide, please. And interestingly, that's why that statement about all cancers becoming rare then flows from that. So in the old days, rare cancers, unusual looking, they go over here. Then there are rare variants of common cancers, and then there are the common cancers. In the new era, it's all about their biology and their genetics, so that in fact, rare cancers have logical biology that fits together with some rare variants of common cancers and even some select subsets of common cancers fitting into different boxes. Next slide, please. But it isn't as easy as it first seems. So we thought, okay, Human Genome Project, Cancer Genome Project, finally we're done, now let's work out how to deal with the information. No, because there's a whole, the body has evolved, the biology is thousands of years of opportunities for homeostasis, for regulation. For every on switch, there's an off switch. That's how we keep that homeostasis. So it turns out that when the DNA gene wants to make the protein that actually causes the cell to do something, it needs another step called RNA. And within RNA, there's a whole range of regulation called microRNAs, and they can go wrong, and they can contribute through loss of homeostasis to the development of cancer. Now we have to understand that as a separate process that needs to be dealt with. And then the proteins themselves, when they fold to create a message, can fold irregularly and not quite give exactly the right message or no message at all. So proteomics, all of these steps together end up with a biological function. All of them can get dysregulated. All of them need to be understood. And there's 2 more emerging phenomena. So there's this phenomenon of epigenetics. So it's not just about the gene going wrong, it's about whether it's open to be read and understood or closed. And what makes it closed? Well, if I want it to be a liver cell and not a kidney cell, I'd like the kidney messages to get closed. But sometimes they get closed when you want them to be open. like a tumour suppressor gene, for example. And it turns out that all sorts of things can cause what we call methylation and downregulation and lack of expression, like toxic chemicals, cigarette smoking. The microbiome is the coolest thing at the moment. All these different parts of the gut that send messages to the rest of the body, and if they're disordered, problems can occur. And this is a new area and really, to me, quite a daunting one to start to understand. And finally, the latest information is something called exosomes. So what are exosomes? They're little packages of information, either protein information or RNA, and very occasionally DNA. This is a murky area just emerging. And tumour cells have the ability to secrete these little bundles of information, and they get taken up by surrounding cells, and those cells then change and potentially immortalise and potentially transform into tumours. So this is a watch this space, that exosomes are probably going to be the next area of great research interest. Next slide, please. So I guess what I'm getting at is that in the 80s, people were really confident. We started to understand that genetic change was the cause of cancer, and the focus was, if we can deal with all of that, we've got no problem. The new understanding is that it's the genetic change, the consequences of the genetic change, the reaction of the surrounding cells to that genetic change. It's a holistic approach which is going to result in success or failure, rather than focusing on just, it's the cancer. That's all it is, those cancer cells. Next slide. And I'll hand back to Michael.
Yeah, so he gives me the easy jobs. So this is a really, really straightforward slide that explains how cells work. But what it really shows is a whole bunch of pathways, and it's deliberately blurred. I don't want you to actually try and read or understand it. What I'd like you to know from it is that there are many, many different pathways, all of which ultimately lead to cells growing. And if you think you want to fix a cell that's a cancer and make it go away, you might be able to disrupt those pathways. However, you'll notice that there are many parallel pathways, so just disrupting one of them will not work unless that one pathway is clearly the target. Now, David's talked a little bit about the biology of cancer and how we've got that understanding. What I'd like to do now in the next few minutes is show you how that understanding of biology, in some cases, has translated to new treatments. And those new treatments lag some years behind understanding the basic biology, but we have those available today, and they are making a difference today. The little rockets there are meant to sort of represent chemotherapy and radiotherapy, somewhat indiscriminate sort of nuking of the cell. They have been the mainstay of our treatment of cancer, of advanced cancer in particular, for many, many years. As we work towards a more targeted approach, I don't think they're going to go away, but we have a whole lot of other things to add. Now, that's my little cartoon of targeted therapies. That's a bird's eye view of the world, and birds go around looking for targets. That's what oncologists do too. We go around looking for targets. And as I said, for many years, we would have regarded chemotherapy as the mainstay of treatment. It's certainly what made David's and my careers. So we are from a generation where that was the way you treated cancer. But towards the late 1990s, things began changing. And the first drug that really changed things is a drug called trastuzumab, which many in the audience might know better by its other name, Herceptin. Herceptin is a drug that targets a particular protein called HER2, which was shown to be important in breast cancer cells, or in breast cancer. And in fact, what was shown was that breast cancers which contained HER2 had a worse prognosis than those that didn't. So the idea came, well, if that's a bad thing, why don't we try and get rid of it? And in fact, this drug was developed and was shown to add to the effects of treatment with chemotherapy. And let me just explain the curve you're looking at, because I've got 3 other slides with survival curves. This is what we call a Kaplan-Meier survival curve. The vertical axis, so the up-down axis, shows the proportion of people, in this case, who are alive. The horizontal axis is time, and the different lines represent different treatments. In this case, the lower line, chemotherapy alone, the upper line, chemotherapy and Herceptin, and it's better to be on the upper line. That has better survival. So that was the start. But in fact, we didn't know at the time, but discovered some years later, that there were much more powerful indicators of what sort of targets we should be using. David mentioned the word driver mutation. Driver mutations are genetic changes that fundamentally give rise to cancer. Not every single cancer has an identifiable driver mutation, but many do. And so the next drug that came along is a drug called Imatinib, and again, might be better known to people in the audience as Gleevec. And this is the drug, perhaps more than any, that really changed the way oncologists, patients, and the community thought about how we should treat cancer. Because what you can see in the slide here on the left-hand side is, at the bottom, is a CT scan with a great big tumour sitting just in there. And after a month of treatment, basically the tumour's gone. The top pictures are PET scans, and you can see the same thing. This black thing was the tumour, and it's largely gone after a month. And in this particular picture, which is actually taken from the first important publication about this drug, patients were followed for a number of months. But it became clear that drugs that affected a particular pathway that gave rise to the cancer were highly effective, could work extremely rapidly, and could work for a long time. And so in this particular case, the target is a thing called c-KIT. It turns out that there's a form of leukemia called chronic myeloid leukemia that has a different mutation, which is also sensitive to this drug. And this was the first chink in the armour, if you like. Now, I'm a lung cancer doctor, so naturally I will show you lung cancer examples as well. And there's a reason beyond the fact that I'm a lung cancer doctor I'm showing you this, because the next real level of understanding came with the understanding of a gene called EGFR. That stands for epidermal growth factor receptor. And in about 2004, it became apparent that about 15% or so of lung cancer, a little bit more than that if you happen to live in Asia, is due to a mutation in this gene. Furthermore, there were drugs available, one called Iressa, another one called Tarceva, that blocked EGFR, blocked the product of that gene, very effectively and very rapidly. And what you see on the picture on the left-hand panel is lots of little white dots in someone's lungs. This is a scan of a lady's lungs. Every one of those little white dots is an area of tumour. There's a scan 2 weeks later, so it's only 2 weeks, and you can see what would pass as a completely normal CT scan of the lungs. So this concept that if you know what the target is and you have something you can aim at that target, that you can get a very good outcome, became one that was established. More survival curves, I'm afraid, but these ones make a very, very simple point. These are from trials in lung cancer on the top and in melanoma on the bottom, but there are a bunch of other examples I could have picked, and they are all from studies that compare a targeted therapy to traditional chemotherapy, which had been used to treat those diseases before. And in every case, the upper line, the better line, is the targeted therapy. The worst line is the chemotherapy. This is in terms of survival, but I can tell you that typically these sorts of drugs also have less in the way of side effects than chemotherapy. That's not the same as saying no side effects, but less in the way of side effects. So this represented a major breakthrough in the way we approach these diseases. Sadly, it's not all good news, because as we started using these drugs, it became apparent that despite very exciting and important initial responses and diminution of treatments, after a period of time, the cancer sort of came back. And if you think about the diagram I showed you with all of those little lines, it's perhaps not surprising. Cancer cells are smart. They figure out a way to get around the blockage. People are even smarter than cancer cells, fortunately. And so researchers began looking at the ways in which that resistance occurs. And again, this is a lung cancer example, but there are similar examples for melanoma and colon cancer and other diseases. And this shows a pie chart looking at mechanisms of resistance. And that great big green blob that says T790M is a particular further mutation that makes lung cancers resistant to the drugs I talked about, EGFR drugs. And we now have a next generation of drugs that can overcome that resistance. And this has been a common theme in lung cancer, where for EGFR we have third generation EGFR inhibitors. For ALK, which is another one of these mutations in lung cancer, initially treated with a drug called Xalkori, there are now next generation inhibitors that can overcome resistance. And in other diseases, for example melanoma, rather than having next generation drugs, it's become obvious that by using combinations of drugs, you can in fact prevent or delay the occurrence of resistance. Now, you have to have been asleep or being way too focused on politics or something to have not noticed that there's a new kid on the block. And the new kid on the block is immunotherapy. And in the business, we like to refer to it as the third big wave. And that's because really, after chemotherapy and targeted therapies, immunotherapies are the way in which the field of cancer therapy is headed at the moment. This is a CT scan of one of my patients. The big red arrow is pointing at a tumour in the centre of this gentleman's left lung. That was a scan done in January of last year. This patient actually happens to be in a clinical trial of an immunotherapy agent and began having treatment soon after that scan was done. And you can see the sequence of scans which don't have big red arrows because there's actually no longer anything to point at. The last scan in the bottom right corner is from August. This person is effectively cancer-free now some 18 months after he started treatment and continues on very, very well. That's exciting, and the advent of immunotherapies is the result of a lot of basic biological work that was done over many, many years, increasing our understanding of how cancers are able to evade the immune system and grow despite your immune system being there with a job of getting rid of the cancer. Perhaps the most exciting thing about immunotherapy is not the individual scan of the individual patient that shows that it's working in one person, but it's the fact that it is the closest we have come so far to a common mechanism that it works across many types of cancers. So I promise this is the last set of survival curves. These are survival curves from 4 different diseases: melanoma in the top left, kidney cancer, top right, lung cancer, bottom left, and head and neck cancer, bottom right. And in every one of these, an immunotherapy drug is working better than whatever conventional treatment it's being compared to. In fact, in the curves on the left-hand side, there's another little thing lurking in the data there, and that is some levelling off of the top of that survival curve, suggesting that some patients are having really prolonged benefit from treatment and may even find themselves not needing treatment for long, long, long periods of time. So this is where the cutting edge is at the moment, and now we're looking at ways of enhancing immune therapy by looking at combinations. Now, in order to study and understand the impact we're having, and in fact to give us leads on new ways to treat cancer, where the other part of the field is moving is to understand the data. I'm going to hand back to David now, who's going to talk to us a little bit about bioinformatics and how that helps us.
So this segues very nicely because, in fact, Michael, who knows how to use this
So
much
this
better than me.
It's that button.
Right,
But
okay, good.
There you go. Oh, yeah, keep going.
Ah, yes, okay. Well, I won't do that one. Yes, yes. Okay, big data. What's it about? You learn a lot from one patient, and in fact, a number of the patients on those really nice curves who level off, they're in the 5%. They're not 90%. But those 5% that we call exceptional responders give us enormous amounts of information about how the biology works and why the drug worked, so that we can find more people who are likely to be exceptional responders, only give them one drug, but add 2 drugs because we learned they're not going to be exceptional responders. So the only way to do that is to look at hundreds of patients' worth of data in order to understand those patterns and then move to the next way of thinking about treatment. It also tells you how cancers behave in humans. So there are some cancers that seem to just spread to one place. In colon cancer, 20% of patients, the tumour only spreads to the liver, it only stays in the liver, and when you operate on that segment of the liver and remove it, they're cured. But the rest of the patients that go to the liver don't stay in the liver and that keeps moving, and they're not cured, and they've had their time wasted, precious time wasted by going through that surgery. And it's only by identifying from large-scale understanding of patterns that you can start to do the right treatment for the right patient at the right time, personalised medicine. It also, big data can tell us about patterns of practice. So we can start to understand whether a particular approach to a cancer is actually achieving the outcome you thought it was achieving, and also identify variation, how to work out why in a particular centre or a particular set of doctors things aren't working quite as well, or working conversely much better than anywhere else. And why is that? So exceptional responders and exceptional treatment patterns. And big data is exactly that. At the patient level, there's an enormous amount of information gathered every day. Every blood test, every chest x-ray, every patient report about side effects is a valuable piece of information. It's even more valuable when it's all aggregated together. I should have had an Australian map, never mind. It's aggregated together because then you can really see the signal out of the noise when it's aggregated together and when it's understood, and that'll be the subject of a talk later on. But if I just take you through this lovely slide here. So we start with the patient on the left-hand side, and we look at their record and what happened to them, and perhaps understand something about the quality of their care. Then we look at a particular practice and all of their records, and we can start to understand more about quality of care and how it should apply to a population of lung cancer patients. Then by aggregating all of that information plus clinical research, new treatments, new ways of doing surgery, different ways of doing radiation, prevention, that affects all of public health, but leads back to the development of guidelines. You learn from all those patterns and you say, this is how we should treat lung cancer. You take those guidelines and they become a policy, but more importantly, within a practice, you look at those guidelines and they help you treat the particular patient. So that's that circle of information that you only get from that mass of big data. We'll get this right by the end of the meeting, I'm sure. No. Next slide, please. That's the backup. Okay, so then we have this thing called clinical registries, and they are particularly important. Clinical registries are a way of reducing variation, improving quality of care, and achieving systems-wide change. Next slide. So, the old way of thinking about cancer registries was pretty straightforward. You collected all the death data, what the death was and what its cause was, and then, as you can see on the left-hand corner, you were able to rank the most common cancer in Australia, the second most common, and so on. The new way of thinking about a cancer registry, and there's just an example there of the Scottish Cancer Registry, and you probably can't see it, but what it does is it collects death information, it collects all the hospital records of treatment, it collects public records and their equivalent of Medicare data, and aggregates that together to learn something not only about how frequent and what the commonest cancers are where you should put resources, but how to do it better. And let's look at a small example in New South Wales. So the Cancer Institute New South Wales looked at survival, mortality and morbidity in esophagogastric cancer. Relatively uncommon cancer, difficult surgery, hard to do, can often cause a lot of morbidity. And what did they find? They found that the 5-year survival was significantly higher in hospitals where more of those operations were done. Still a relatively modest number. The cut-off point was 6. So that includes a number, but not all hospitals where such surgery was done. And it was 28% worse outcomes in the lower volume hospitals and 83% worse for gastric cancer. So let's try again. No, next slide, please. Okay, and even more important, let's look at the prostate cancer one, where 28 hospitals in Victoria decided to contribute to a clinical registry. And they, as you often do in these clinical registries, the groups of people, in this case the surgeons, get together and they say, okay, let's pick some quality indicators that we believe really tell us how well we're doing in treating this cancer. And let's see, by aggregating information, what we can do about that. And here's the key. It's not just about collecting the information. This clinical registry feeds that information in real time back to the practitioners. So very quickly, what did it show? It showed that people with low-grade cancer, where intervention does not alter survival, there was a drop from 55% to 34% over 5 years in the number of people getting inappropriate treatment. There was an increase in the number of people getting appropriate treatment of over 4%, and the number of people who got surgical approaches that left cancer behind dropped by over 50% over 5 years by using a clinical registry in real time for the people who need to know the information. Finally, as you've just heard, complexity of care is increasing. You cannot have a molecular tumour board on every corner and in every hospital. So we need to look at new measures like telehealth. This is our colleague Sabe Sabasan in Townsville, providing support to a patient 500 kilometres away in Western Queensland. I used to fly from Tamworth an hour to go to Moree to see patients. We don't do that anymore. We use this kind of information, and the same applies to that really complex Michael sitting in a molecular tumour board looking at all the latest treatments that might be possible for that 2% group, sitting with a group of experts, bioinformaticians, statisticians, clinicians, surgical, medical radiation, and a clinician in Townsville or Burke can ring in and have access to that enormous amount of practice-changing information. These are the ways we're going to have to deal with the complexity and the subspecialisation that we need to do this well.
So we're nearly into the home straight. I know Sophie's itching to get back up here. So this will be very brief because we're at the point now where I just want to turn the focus a little bit away from drugs and treatments to some of the system-wide things David is talking about. So to get cancer care right, it involves a lot more than just having drugs PBS funded or drugs developed by clever people in laboratories or better operations. There are a whole host of issues that need to be dealt with to ensure that every patient gets access to the right treatment for their tumour. And some of those issues really relate to the way that care is organised. How do you ensure, when you saw the sort of data David showed you about volume, that people have access to centres where the volume is being done is adequate to make sure that the expertise is maintained? How do you, if you're going to do that, how do you make sure that the job is worthwhile for the people that work in the smaller centres so that they're still interested enough? How do you know that the people have the right education? How do you know that people are working together? And so wearing my other hat, which is a health administrator type hat, I ponder those things, and I can tell you that the answers aren't always clear. However, it forms part of the challenge and part of the opportunity we have, because we know from a variety of diseases, and mostly in fact not from cancer, that there are often delays in getting best practice established. In other words, we make discoveries about the best way to treat a disease. There are often delays before that is adopted system-wide. So finding good ways to rapidly translate research findings into the system, into the healthcare system, has become important, and in fact has spawned an entire area of research called implementation science that is just as important as some of the basic science that gives us the advances that we rely on. Now, to do that requires, as I said, enormous collaboration. It requires collaboration between centres. It requires collaboration between professions. And by that I mean between different types of medical practitioners, between doctors and nurses, doctors and researchers, and so on. And that actually is something that I think sometimes gets overlooked when we talk about the advances we're making. It is not enough to just fix the drug problem. While we're on the drug problem, I think it is worth pointing out that the tremendous complexity that we have described today is a true challenge, I think, in the regulatory environment. So having new drugs that deal with small subgroups of patients is something that does not fit into the model particularly well of how we have thought about this previously. And obviously our agencies do the best job they can, but I think this will require a bit of a quantum shift in thinking in order to make sure that patients in Australia get rapid, timely access in an affordable way to the things that we have begun talking about today. The final point that I'd like to leave you with relates also to that complexity. If you're a patient, it is difficult to navigate this system. In fact, quite frankly, if you're a clinician like David and myself, it is difficult to navigate this system and to understand it. And so when we're setting up our services, I think we have to be considering the person that is the consumer of those services. So it is not enough to simply say, we can give you this treatment. We have got to make it easy for people to find their way to the treatment, make it easy for them to deal with the complexity of negotiating the system, and ultimately let them get what they need. I think we can be confident and look forward to a future where we will make even further inroads into cancer. What we've shown you today is a little glimpse of this, and I think this will go on. However, to do so will require the sorts of collaborations that I have to be honest and say in Australia we've been pretty good at, but we will need to be even better, because it's only by us all working together, and that includes the advocacy movements and the consumers, that we will actually get there and show the people who make some of the decisions what decisions need to be made to support high quality care. And with that, I think we will stop, and we're happy to answer questions if there's time.
That was a fantastic presentation, so insightful and so important. I was just going to ask you, really, what you alluded to at the end of your discussion about how much faster is science progressing than the sort of regulations that govern what access we have to medications?
So, look, I think it's not straightforward because, yes, science progresses quickly, but there's also excitement followed by reality testing, followed by massive depression, didn't work at all, and then ultimately recognition, it does work, but we need to know who for. So I have some sympathy with regulators taking a bit of time to think through where the value lies. So the challenge to us as a community, advocates, as well as practitioners is to demonstrate that value early on, to be thinking about implementation science and benefit and looking at the right drug for the right person with the best bang for buck. And these are all the things that we need to think about more carefully. We often also get excited by the wave of excitement, and we don't stop to think, well, how can we prepare for its introduction into the real world? So we have challenges just as much as our regulators.
Yes.
Would you agree with that?
Yes, I would agree with it. I would add just one thing, and that is that the thing that I would like to see eliminated, if you like, is the disparity between countries. To me, it's not acceptable that a drug that has been shown to work is approved and used in routine and therefore has the sort of data that David's talking about in one country, and we have access to it here 2 years later. And that's the sort of disparity. And it's not, and I shouldn't pick out Australia. I mean, we're standing in Australia, so obviously it's important, but that disparity might exist in reverse sometimes. And that's the thing, if I would look at it, I would say it's the low-hanging fruit. It really is.
And that may improve in the future with some of the changes that the government's
Yeah,
looking at
absolutely.
with FDA and EMA submissions. But
Yeah.
excellent points and a fascinating and a fantastic way to start our sessions today. So please thank our presenters. We're going to have that was really wonderful. We're going to have a short break now.